Health and Safety Committee. We do have a quorum with myself, council members Benton, Bradford, Kimbrough, Nash, Porterfield, Prep T, and Weiner. I do have a proposed consent agenda of item, and I'll go ahead and just read the item number. We don't have a very long agenda. Item number 1, 2, 3, 4, and that's it. Does anybody need any of the items 1, 2, 3, or 4 pulled from the consent agenda? Councilmember Kimbrough, let me recognize you. If you, no worries.
I was just saying, can you give me 1 second?
Oh, of course. I can go ahead and read, and then that way,
Okay.
if anybody wants to pull anything off, we can do that. All right. Welcome, Councilmember Huffman. First item on the proposed consent agenda is item number 1, RS 2024-881, Porterfield, Evans, and others. Accepts a state crisis intervention program grant from the Tennessee Office of Criminal Justice Programs to the Davidson County Juvenile Court to provide mental health services and mentorship programming opportunities for the Juvenile Court Gang Resistance Intervention Program. Item number 2, RS 2024-889 by Porterfield and Evans, approves Amendment 1 to appropriate additional grant funds from the Kresge Foundation to the Metropolitan Action Commission for general operating support. Item number 3, RS 2024-892, Porterfield and Evans, approves a contract between the Metropolitan Government and Versaterm Public Safety US Incorporated to provide upgrades, maintenance, and support for LIMS Plus software system for the Metropolitan Government of Nashville and Davidson County. Item number 4, RS 2024-893 by Porterfield and Evans, approves a sole source contract between the Metropolitan Government and Intergraph Corporation through the Hexagon Safety, Infrastructure, and Geospatial Division to provide maintenance services for records management systems utilized by the Metropolitan Nashville Police Department. Does anybody have any of these items that they'd like to remove from the consent agenda? Nothing? Okay. All right, then. Do I have a motion? It's been moved and properly seconded. All those in favor of our consent agenda, please say aye. Anyone opposed? Anyone not voting? All right, you recommend approval of our consent agenda. With 9 in favor, 0 against, 0 not voting. Okay, let's go to item number 5, RS 2024-905 by Eastlick, a resolution urging the Metropolitan Nashville Police Department to increase traffic enforcement and the Nashville Department of Transportation and multimodal infrastructure to improve the physical environment for everyone using the road. I do have a letter to defer for 2 meetings. Do I have a motion? All right, it's been moved and properly seconded. All those in favor? Anyone opposed? Anyone not voting? All right, we recommend a 2-meeting deferral. Okay. I want to bring our guests up, and then we'll do some announcements from myself. I want to also at that time recognize Councilwoman Porterfield for an announcement, and then we'll take any department updates. And I'm aware that we've got some folks from Meharry about Dry January. Happy to recognize you after we get through this presentation time. So I'll welcome Captain Anthony Brooks and also Mike Randolph. Captain Brooks, of course, is with MNPD. You can tell by his uniform. And then Michael Randolph is with Mental Health Cooperative. And I invited them to come and give us an update on Partners in Care. Yeah, give your microphones a little test. I believe I turned on the right ones.
Check. All right. Check. You good? You ready? All right. First of all, I'd like to thank members of the council and the Public Health and Safety Committee, and especially Councilmember Evans for inviting us out here to share. Partners in Care is something that's near and dear to our hearts. It was the flagship program of the Office of Alternative Policing Strategies. For those of you who don't know, she introduced me, but my name is Anthony Brooks. I oversee the Office of Alternative Policing Strategies with the Metro Nashville Police Department. We were created in 2021 And the first project that we were given was to create the Partners in Care Mental Health Co-Response Program. Back in those days, it was Inspector David Imhoff who led the office, so I'm sort of standing on the foundation that he built when we're here to talk about this today. And a lot of this came about in order to simply address mental health crisis calls out in the public with first responders. There's a lot of opinions about how those should be handled. There's a lot of opinions that think that those in my profession should not be interacting in some of those incidents as much as we do. And there's certain times I would probably actually agree with it. The issue that we have, though, is that the general public doesn't necessarily see a mental health crisis out in the world and say, oh, that's a mental health crisis, we should call a counselor. A lot of times they just think something bad has happened and we should call 911. And when a 911 call comes in, law enforcement and or fire is going to have to respond. So whether we like it or not, we're going to be involved in these interactions. So there's a couple ways to go about handling them. There's what we do with Partners in Care, which is a mental health co-response program. And there's another model that is not law enforcement involved. That's usually a model that has EMTs or fire paired with social workers and things like that, which we actually do have in Nashville now. That's a sister program to Partners in Care. We won't get into much of that today, but that's the REACH program. Some of you may have heard about it. I'm sure Michael would like to come back at a later date and talk more about REACH. But since we're on Partners in Care, we decided that we wanted to start with co-response because in these interactions, like I said, we're going to be out there whether we like it or not. So this is a good way to equip officers with the tools that they need to address mental health crisis and behavioral health crisis calls in the field. So we started it with the goals of we wanted to improve the access to care for those that are experiencing a behavioral health crisis. If you are in crisis, if you are suicidal, if you're having delusions or these sorts of things that put your safety at risk and the police show up, prior to this, one of our only tools that we had was to arrest and take you to jail, and hopefully maybe things would get sorted out in mental health court. So that's not great access to care. So partnering with Mental Health Co-op, we're able to improve the access to care to where we can start plugging people into the proper services on the front end. Along those lines, our second goal is diversion out of the criminal justice system and into the mental health care system. As I mentioned, one of our few avenues we had previously was arrest, but unfortunately, being locked in a cell, cinder block walls, bars, that's not a great thing to have happen to you if you're undergoing a mental health crisis. So we wanted to minimize that as much as possible. We also wanted to improve the communication across systems of care. Mental Health Co-op is able to help us with that through some of the connections they have. If we encounter someone in crisis, we're able to figure out the best possible place and talk to different systems, hospitals, avenues of care to get them plugged into the proper services. And the last goal that we set, which is not the least important, even though I mentioned it last, and that's safety for everyone involved, the officers, the clinicians, the consumers involved in these interactions. So as I mentioned, we started in 2021, and what I'm going to do is give you a brief overview where we were, where we are, where we'd like to go, and then we'll turn it over to Michael here, and he'll talk a little bit about some of the stuff they're doing on the mental health co-op side. But we started in 2021 in two of our precincts, the North and Hermitage precincts. We ran that as a year-long pilot. We collected the data to ensure that this was something that was going to be helpful. If we ran it for a year and our data was showing that it wasn't helpful, it wasn't improving these interactions, it wasn't accomplishing our goals, then we would have scrapped it there. There's no sense in spending any more money. But at the end of a year, we found out that this is really a successful model. And we were doing a lot of good. We were connecting people to the proper care. We were accomplishing a goal of diverting out of the criminal justice system. At the time, I think in mental health crisis interactions, the arrests we were making were in about 4% of those interactions, which we felt was like a pretty good number. It's up a little bit to about 4.5 now. And one of those reasons, I think, is because I'm happy to announce, if you hadn't heard, it was earlier this year, but we are now a countywide program. We expanded to our 8th and final precinct in May of this year, which was our West Precinct. And just so you know, all of our decisions are data-driven. The decision to expand in the manner that we did to the precincts that we did was all based on the need. So we analyzed the amount of mental health crisis calls that would come into certain precincts. West Precinct ended to be the one with the the lower need. So as we expanded, we went just greatest to least. We were excited to get there. And one thing that's been really fun to watch as we rolled this out is I might have used this phrase the last time I spoke up here, but I know that if there's two things that police officers hate, it's the way things are and change. So when this program came about, there was a lot of pushback because they didn't want to have to do things new and they didn't want to have to learn new skill sets. That quickly went away. And I think a lot of that has to do with how we've communicated to our officers, the training that we've given them, the messaging that we've given, the usefulness of the program, because they saw very quickly that this was a great tool to keep them out of booking rooms when they don't need to be, because historically they've thought taking somebody to jail is a quick way to improve this situation because they can book them and get back out on the street, answer other calls for service. And if you handled mental health route, sometimes they'd get stuck at hospitals and have to sit there. And so this program has actually seen a decrease in hospital times, and with them finding other avenues, they're not even having to spend the time to go to booking. So there's officers that recognize the value there. There's also a great number of officers who just have a heart for service and helping. That's the one thing that we forget is that a lot of times when, we see a lot of our interactions with law enforcement are not always positive. You don't encounter police officers unless either you're doing something wrong or something bad happens. You're speeding and an officer pulls you over, and that's not a fun interaction. But as we communicate the program and the way we're going to do these things to officers, we learned that the main reason we got into this job is to help people. And so one of those ways is to be able to have the tools in these mental health crisis situations. The way we do that is each officer that is paired with a clinician from Mental Health Co-op receives an extra 40 hours of crisis intervention team training. Through that, and Michael can talk a little bit more about that training because that training is put on by Mental Health Co-op to our officers, but they learn about different resources they can use. They learn how to spot signs of different mental disabilities, mental health crisis, and then they're able to better make decisions. As I mentioned, some of the messaging that helps with the officer buy-in, one thing that we also do is we talk to them a lot about the laws involving mental health crisis interactions. There's been a misconception, I think, historically nationwide amongst a lot of law enforcement officers that if there is a use of force, then an arrest must be made, which is not the case. There's definitely federal case law that has upheld uses of force in situations where there's a medical emergency, where someone might have to be restrained, or if they're not thinking clearly, their force might have to be used to get them the proper level of care. And I know that it might sound a little weird sitting up here saying we're justifying a use of force on a mental health crisis call, but they need to know legally what they can do because it does create a better outcome. In the rare occasion when we do actually have to use force in these calls, if we were still operating under the old assumption that someone would have to go to jail if there was a use of force, then anybody that even if it's a low level of force, they wouldn't get the level of care they need because they would end up in a jail cell. So officers are instructed on the different liabilities and the different things that they can do and the different tools that they have at their disposal. And as I mentioned that, in all of these interactions, we're seeing a very low use of force rate, which is only at about 2%, which is lower even than our arrest rate. So it means if those that are going to jail aren't even having to be used force to end up taking them to jail. And even in those uses of force, they're very low level things that we call soft, empty hand control and restraint. So our training is able to get officer buy-in that way. Another thing that we do that has made this a success is, as I've been around the country and talked to other people that are doing this type of work, one of the roadblocks that they've had is friction between officers and clinicians. Sometimes you might have a program that just says, okay, you're a mental health clinician, you're a police officer, and then they just stick you in a car and say, go do God's work. And they didn't give them a whole lot of guidelines and didn't really educate them that they're on the same team. We wanted to learn from that. So we end up putting our clinicians through a couple of days of training on police policy and procedure. If you have a clinician that's looking at a situation from a clinical side, and then an officer is looking at it from a law enforcement side, sometimes those things don't always match up because there's certain things that officers have to do based on officer discretion and certain laws, domestic violence being one, where an arrest might have to be made even if it is a serious mental health crisis situation. The clinicians need to know that because they don't need to be arguing in the field. So we put them through that training. They know what we need to do as officers. And granted, it's only a couple days, so they're just given a baseline. They're not taught to be police officers, but they know that this is the part of the team that they're coming into. And then with the CIT training for the officers, knowing how the clinicians are looking at things, and then this training for the clinicians, knowing how the officers are looking at things, it creates a better partnership and a better team out in the field. These clinicians are assigned to a patrol detail, and they go to our roll calls every day. And there's a lot of ownership there on both sides, the police and mental health co-op, to this team. So we've seen a lot of success since we've started these calls. And I should mention, they are attached to patrol. We don't have a specialized unit that does this. So our clinicians basically do full-time ride-alongs. So they ride around with police officers, and they go to other calls for service that aren't mental health related, which is helpful because sometimes it's good to have a mental health clinician there and available to talk to somebody that might be a victim of a violent crime or things like that. So there's been an ancillary benefit that we didn't even consider. Since we started the program in 2021, we've answered 41,000 calls for service. Now that's overall, that's not just mental health. Of those, just over 8,300 have been mental health crisis calls. So you can see that we are going to a lot of things that aren't necessarily mental health related, but there's benefits there as well. One benefit, which we won't really get into, but Michael and I are preparing to speak on this in the middle of next year at a conference, is that our clinicians actually responded to Covenant School during that shooting. And they were able to help with the kids and with the families during reunification process. And so that was a benefit that we never intended that we would have with this program. But man, we were really happy that we had officers and clinicians on scene with that training. Speaking of the officers training, and this will be my last point before I'll turn it over to Michael, we want eventually every officer assigned to our patrol division to have received the extra 40 hours of crisis intervention team training because we are currently, I said we're countywide, but we are only Monday through Friday, and we're only on the day and evening shift, which means there are still going to be officers, especially on the midnight shift, who might interact with those in mental health crisis who don't have the resource of the clinician. So we think it's important for them to at least have the training to help guide them through these interactions. So we want everyone in patrol to have received this training. Currently, we have trained about 364 officers in crisis intervention team training. 258 of those are still assigned to patrol. The reason those numbers are off is because sometimes people transfer into investigations. We do have other specialized units who will say, hey, can I get a few of my officers in there because they think it'll dovetail well with what they do. And then supervisors in patrol, we've trained 82 and we've trained 108 overall. So we're over almost 475 of our officers have received this training, and we continue to do this training month by month. I see our training director, Amy Werner, just walked in the back, and she's a employee of the Mental Health Co-op and partners with our training academy to help put these trainings on. One more point about that is we have also trained a large number of fire department personnel in crisis intervention team, which we thought was very important when we started the program. So they could, as they're going to be going out in the field and responding to certain calls with their EMTs and ambulances, and they see our councils, they'll know what it's about. They've learned a little thing or two about how they can better respond to mental health crisis calls, which help dovetail right into the creation of the REACH program. I could talk about this all day because I mentioned it's pretty near and dear to our hearts. We really believe in the work we're doing here. I've been fortunate enough to speak on this at a couple of different conferences and advise other departments on best practices for these sorts of things. So it's something that I could go on, but then so could he. And if I go on, there will be no time for Michael to speak to you about what the Work Mental Health Co-op has done in our program. So I'm going to turn it over to him.
Thank you. And thank you, Councilwoman Evans and other councilpeople for Public Health and Safety Committee for having me here today. My name is Michael Randolph. I'm a licensed professional counselor and the director of the Partners in Care program and REACH programs with Mental Health Cooperative. I'm going to give you kind of a brief overview of what the program is, adding to what Captain Brooks said, and kind of spotlight some of the areas that are not widely known about what we're doing in Partners in Care. Right now, we have a counselor in every precinct Monday through Friday from 6 a.m. to midnight. They show up to those precincts. It's day shift and evening shift. They only ride with officers who's gone through the crisis intervention training. We learned through the pilot that rotating those officers is good, and it helps with burnout and helping those officers stay excited about doing that kind of work. As of May, we were all in all 8 precincts. And as of Monday this year, we've answered 3,400 mental health calls around and about 20,000 other calls for service citywide. Our program targets the highest acuity mental health crisis calls in Nashville. The safety of people in crisis is utmost important. And the data really shows that we are going on those calls. Out of those 3,400 calls, about 55.5% had to receive a full mental health crisis assessment. That means that this individual was having some suicidal ideation or a suicide attempt, homicidal ideation, or some level of psychosis, or all 3 going on. It's not a if or. It's sometimes your crisis can be suicidal and having delusions or hallucinations. We were thankfully able to resolve about 55.5% of those calls at the home with a safety plan or follow-up plan with these individuals. Unfortunately, 34% had to go to an emergency department, either for medical clearance for inpatient hospitalization or for a medical concern such as a suicide attempt or acute intoxication. About 6% went straight to our crisis treatment center and Metro Center here with Mental Health Cooperative to begin their mental health treatment, and another 5.5% went directly to a psychiatric hospital to receive treatment. Out of all of those 55% of calls, about half were actively suicidal at the time, 10% had homicidal ideation, and 45% had some sort of delusions or hallucinations going on. And those can also be a combination, as I said. So you have a counselor day shift, evening shift at each precinct. Every 2 precincts has a supervisor who is also a counselor, a clinician. That supervisor, they ride in those 2 precincts. They provide clinical supervision for the counselors, do note review. They build partnership with those precinct police leadership to resolve operational issues day to day. And they also work with local communities in that precinct and resources to really build that partnership and collaboration to get people the help they need in those communities. A surprising statistic we found in the pilot that's continued to this day is about 75 to 80% of the people we serve live in a house, an apartment, or a group home. We thought there'd be a higher number of unhoused. But in Central Precinct, that's actually reverse, where 75 to 80% are unhoused. So what we've done in the Central Precinct, and Captain Brooks helped create this, is our counselor is embedded the Central Quality of Life team. That is a special team of officers who have a heart for working with the unhoused. That counselor and those officers still answer emergency calls, but they spend every day building relationships with the unhoused. They check on the camps, they give out food with Salvation Army, and they're able to build relationships where an individual in that camp might be like, someone over there in their tent is not doing well, can you check on them and take them to that person? That team has been able to find over 100 people so far this year housing out of the downtown district, and it's really, I believe, a model for how we should handle some of these situations in the future. So far, we've had no counselor injuries on any sort of mental health crisis call. In the last 2 years, we've been able to add 2 follow-up coordinators to the Partners in Care program. Individuals who receive services through Partners in Care, either themselves or their families, are the community called 911 or 862-8600 to get them help. They have 3 levels of follow-up. If they are part of that 55% that receive a full crisis assessment, they will get up to 3 follow-up calls in the first 24 hours. Our follow-up coordinators will call every individual we make contact with in Partners in Care who agrees to it within the week to check on them and offer them resources. These follow-up coordinators, one of which, her name is Ashley, and she's a certified peer support recovery specialist. She will make contact with the person, offer resources, and in some cases offer short-term case management and really get into these cases to get the help people need so to ensure that they don't call 911 again. And I'll go into a story at the end that really highlights what this program is trying to do. As Captain Brooks relayed, we have a CIT training coordinator, Amy. We also have 2 of our supervisors here, Violet, who is in charge of Central and Hermitage Precinct, and Ashley Blair, who is supervising East and West Precinct here today. Thank you for coming. Amy is our training coordinator, and she's actually embedded in the police academy, where they've asked us to really take a look at how we do mental health trainings for new cadets, for CIT training, and really improve everything. And these CIT trainings are 40-hour trainings. We put on one a month. Next year, we were going to start with this summer with training the SROs specifically in the summer months. And at this training, we have guest speakers, lectures, we have virtual reality headsets, role-playing, reality-based training, and other methods to teach officers to recognize the signs and symptoms of mental illness, de-escalation, and really connecting a person in crisis to the proper resources.
I'd like to step in for 1 minute because I want to mention something because I know he's about to touch on it from the clinical side. But one of the reasons that we're putting our SROs through this training is as we were looking for areas for expansion, and I was discussing, as we mentioned, that we were involved on the periphery of the Covenant school shooting. And as I was talking with the commander of school safety at the time, we found out that there's a lot of incidents where they encounter mental health situations or they need a full mental health evaluation on some of these individuals. So as part of Partners in Care, we actually formulated a plan, and under the program, we have assigned a counselor to our school safety division as well to be able to assist with those. And so our training is now starting to fold in school resource officers so that they're better able to deal with mental health crisis situations within the school system. Now, they partner very well with the Metro Public Schools because they also have their own counselors. We're not trying to do their job. We meet with them frequently so that we don't overlap and there's no redundancy. But we do have that resource now in the school as under the Partners in Care umbrella. And I know that Michael was going to mention it, and I realized I gave no background on it before he got to it in his part.
Yes, thank you. At the Academy and as the Partners in Care program, we've been able to design reality-based training for cadets who go through the Academy and for our CIT officers who go through the CIT training. And we were able to design the rubric for how officers are graded in their de-escalation and mental health crisis at the Academy. We've been able to streamline all training that the cadets receive to be in line with the CIT training, incorporating community resources earlier and giving officers more tools to de-escalate earlier in their careers. We've also partnered with the negotiator and SWAT teams about mental health callouts there. The negotiator team asked us to help. Recently, we had a training exercise at Green Hills Mall where we were able to help design mental health scenarios, and our supervisors and myself acted as role players for the negotiators for people in mental health crises with common callouts that they go on to help train new negotiators on their de-escalation skills and those kind of calls. And as Captain Brooks talked about, we have embedded a counselor in the school safety division in response to the increase in mass shooting, school threats, and the change in state laws to make sure that these kids receive a mental health evaluation if they're going to interact with the police in a threat assessment. And really to help if kids are going to have to interact with the police department more to ensure it's in a trauma-informed way and to protect everyone involved in these crises. We've developed a great relationship with MMPS and the Director of Counseling Services to really make sure none of these kids fall through the gaps that need services who make some of these threats, because generally there's a lot of things going on in their lives. We want to make sure that they're connected to the right care. We've invited public schools to give input on how to train SROs during their CIT training, and they're going to come and be guest speaking and then help give input on what topics to train those officers on to ensure that the officers who are in our schools will be the best trained for mental health crises that are common in schools. And I really wanted to kind of end things and open things up for questions with a story of what Partners in Care is about. This is a story of an individual who lives in the Hermitage area. He called 911. He was suicidal. He was armed with a handgun. The PIC car, the Partners in Care car, the team answered the call with other officers. This individual, he was very paranoid. He was experiencing psychosis, delusions, hallucinations, and was actively suicidal, and he had the handgun. Officers on scene were able to de-escalate him and get him to hand over the handgun. The counselor on scene was able to give a full assessment. We were able to get him to a hospital right then to begin treatment. Our follow-up coordinator reached out after he got out of the hospital to check in on him, because during the crisis, we noticed that methamphetamine use was a big factor. And we know that it's a struggle to be able to recover from that kind of crisis with that kind of substance use disorder as well as part of that. Our follow-up coordinator was able to get him into a partial hospitalization substance abuse program and create that relationship. To the point where he actually relapsed 3 times after this call that was in August. And he called our follow-up coordinator each time. Instead of calling 911, he's like, I need help, I'm back there. To the point where we were able to get him into an out-of-state residential treatment facility where he completed that treatment facility and has stayed recovered since that time. And he has not had to call 911 or 862-8600 for his crisis since then. He stays in contact with our follow-up coordinator, and she wanted me to say that he told her that she saved his life and we saved his life, but really he saved his own life, and our partners in care teams just encouraged him to do that. And that's exactly the type of call that this program is designed to do. And it tells you that these cases are very complex and they need a lot of help to make sure that they stay in recovery. And I appreciate your time.
Thank you so much for being here. Are there any community members or committee members that have questions? I saw Councilmember Prepty, and then we'll go to Councilmember Gregg. Councilmember Prepty, you're recognized.
Thank you, Madam Chair, and thank you all so much for being here and sharing this incredible information to the committee and to the public at large. My first question is, could you say again, so like the public who's here and those who are watching, could you say again the number that people can call that's a non-emergency number to get access to any kind of counseling or anything if they're in some kind of crisis?
Absolutely. So you can always do 988 for a talk line. The mental health crisis line for Davidson County is 615-726-0125. If it's an emergency, you could call 862-8600 or 911 if it's an extreme safety emergency. Our philosophy of mental health cooperative that there's not a wrong door approach here. If you need help, we're going to get you help no matter who you call.
Perfect, thank you. And then Captain Brooks, could you let us know, with this specifically with the Partners in Care program, about how many clinician and CIT trained officers are there per shift, if you know?
This is going to be approximation, but because also the patrol details differ in size. So central precinct's going to have less, but on average, we would probably have 7 to 10 per shift. And we do that, when we started, we trained 4 per shift on the pilot program because we could only put 16 in a class. We had a day and evening shift at 2 precincts, so we had 4 volunteers from each one. And that's really the bare minimum with everybody's days off that you can rotate and not burn an officer out. So with that number of officers, we feel like we can get a pretty good rotation, and so that we're not constantly exposing officers to some of these calls for service can be pretty mentally taxing. And as I like to say when I'm training officers, previously before this program existed, if a mental health crisis call went out in a certain zone, that zone officer would get it. If the next one went out in a different zone, that zone officer would get it, and so on and so forth. So if you went through a course of a shift and had 5 calls, they could potentially go to 5 different officers. Since the creation of the program, those 5 calls are going to go to the officer that's working that particular assignment that night. And we don't have the mental health training that they have. So sometimes that can weigh pretty heavily on the minds of an officer. So we want to make sure we have a pretty good pool to rotate them around so they don't get burnt out, so they don't end up experiencing compassion fatigue in some of these calls.
Perfect, thank you. And then I'll have 2 more questions before I pass it off to my colleagues. This question you might not necessarily be able to answer right now, but what I would really like to see is, out of these calls that have had to result in an arrest, whether or not, or if there's any percentage of those that have been specifically after they've booked being referred to the behavioral care center that's housed here downtown at the DDC, if there's any type of percentage, I see you shaking your head, Mr. Randolph.
I don't have the specific percentage for BCC. There's a mental health team in jail, and we partner with them, the BCC and the Davidson County Sheriff's Department. I know that of the 4% arrested. About 75% of those charges get dropped due to mental health care received there in jail. And we do partner with them quite often. It's a warm handoff where the counselor is talking to the mental health professionals in the jail. So that person, even if they do get arrested, and that's worst case scenario, we were able to meet them, walk them in with them, and then have that clinician inside the jail talk to the counselor on the phone before we even get there, so they're able to take them and try to get them the services they can when they get there. I just know that 75% of those charges get dropped eventually. Last time I checked that stat. I don't know the exact number who's gone through the BBC, but we do, we try our best.
Well, and one thing that's been good about that is prior to having the mental health co-op along with us on these calls, we didn't have that direct connection to the team that's working in the jail. So even if an officer recognized that this is a mental health crisis, an arrest had to be made for whatever reason, so they want to drop them off, and if they notify somebody at the sheriff's office, that connection might still not be made, just due to whatever reason. It's like but with this particular, as he mentioned, the warm handoff, the clinicians in the car could already be on the phone and say, hey, we're bringing this individual down. We don't have another avenue. We have to bring them down, but they do need services. And that connection is a lot more efficiently made through the use of this program.
And I will say on our program, the last time we ran this data, and we can verify it with Health Department, is the vast majority of these arrests were active warrants, not from the crisis call going on.
Perfect. And then my last question is really kind of more of a statement to both you, Mr. Randolph, and Captain Brooks, as well as you, Chair Evans. If we could, I'd love to see some more reporting as to sort of like demographic breakdowns as to members of the public who are able to utilize this care that you all are providing. Because I'd be really interested in seeing that. And then I also would love to be able to have a one-on-one conversation with the both of you all as to how we can expand this program to where what resources would be needed to make sure that it's a 24/7 service that we're able to provide. But yeah, thank you all so much.
Yes, sir. And to
The
your
first one,
point
yeah.
there, that data is put out quarterly. It is posted on our website, Office of Alternative Policing Strategies, and also Mental Health Co-op post that as well. And please feel free to reach out. Any conversation you'd like to have, I'm always happy to.
A major
make those
tenet of our
connections.
program is data transparency. So it is published on Nashville.gov every quarter. And the Health Department updates that with all of the demographic information and a snapshot of what's going on in the program that quarter.
Thank you. Councilmember Gregg.
Thank you. First, I want to applaud the innovative work. Myself, when I'm not wearing my council member hat, I'm also a therapist. And I can only imagine the impact of the lives that you're making. But my question is this. I can't see a patient unless they consent. How do you handle that process? If you go out to a call, you determine there needs to be an assessment. What happened? Do they have to consent to that assessment? How do you handle that?
So in the state of Tennessee, Mental Health Cooperative is the designated crisis provider for Davidson County. So we have the mobile crisis contract. It's a situation where if police came to this call without a counselor there, and let's say they were called to the scene because the individual was suicidal, and they say, I don't want to talk to anybody, but they posted on Facebook, I'm going to end my life. They are legally obligated to call the designated crisis provider, and we can go and try to assess and get consent when we can, but because of the crisis time, we have the consent, we are able to, oh my gosh, I can't think of the word. We are able to perform a crisis assessment without consent if it's a matter of life or death in a mental health crisis in the state of Tennessee.
It's similar to, and if I see a colleague from fire in the back, they could correct me on this if I'm wrong, but you have to consent to medical care. Mm-hmm. However, if there's a suspected serious head injury that is preventing them from making rational decisions at the time, they can actually compel someone for medical care. The mental health law is similar to that.
There's a lot of exceptions for suicidal and psychosis and type of crisis. For our follow-up program, we have to have a release of information and consent to that. Yeah.
Okay. So for the follow-up, that is required?
Yes. Yes.
Okay. Well, thank you again.
Mm-hmm.
I'm going to jump over to Vice Chair Huffman, then I'll come back to you, Councilmember Coopin.
Thank you, Chair, and appreciate you guys very much. The work that you do is very underreported, I will say. And yes, we do have a mental health crisis, a very big one. The fact that you highlighted 3,400 mental health calls just in 1 year for REACH is remarkable. So I've got a few questions. I'm going to start with some general questions, and then I've got two particular to the unhoused community. The first question I have regarding staffing levels. You said you've got 2 folks per precinct working 6 to midnight. You feel like that's adequate right now, handling the calls?
So right now, we have a counselor embedded at each precinct, day and night shift. So 8 should be working at any time. Now, of course, people take off work or get sick. I think the first area where we need to work on is we're data driven. We make all data driven decisions. So we're not Saturday, Sundays. So we're probably missing 20 to 25% of mental health calls on Saturday, Sundays. We've been able to staff up with the current way that the program is structured, with supervisors to provide supervision, counselors to be in the car and to answer the call. So I don't have the data on what calls we're missing during Monday through Friday, 6 a.m. to midnight. I actually asked to start gathering that data, so we're going to have more answers on that in the foreseeable future. But I think the first step is the days we're not running. That's probably the first place we need to expand, and then look at do we need to staff up on days we're already running?
Okay, all right. Thank you.
Because we also triage based on level of emergency. You can talk more about this, but a code 3 versus a code 2 mental health call, where it's an emergency lights and sirens, or one where you don't need lights and sirens to respond, the counselors go on the emergency calls first, because our job is to respond to the highest level emergencies with them.
Got it. Thank you. What about in instances where you've got a standoff or a hostage situation? What's your policy for your counselors in those instances?
So anything like that would immediately generate a call for crisis negotiators. That's one thing that we make sure the counselors know, that they are not crisis negotiators as far as situations like that. We have officers trained to handle those situations, then they can actually handle them in a lot better manner sometimes than the clinicians. Now, there is also going to be a mental health aspect in a lot of those situations, and because of that, even long before the creation of Partners in Care, our police department and our crisis negotiation team has partnered with Mental Health Co-op to have a mental health advisor on scene during those interactions. Michael is actually attached to our crisis negotiation team as well. So if a negotiator call out goes out, then he would respond to that as well, to be in an advisory role. Along with I think they got a few people over there that are able to do that. So that's anything that escalates to that level is outside of the purview of Partners in Care, because as far as policies and stuff that protect our counselors and clinicians, as Michael said, so far we have had 0 injuries to any clinician on any mental health crisis call. And that's because we hold their safety in the highest esteem, and our officers are instructed to stabilize those scenes prior to allowing a mental health clinician to interact with somebody. So we would never allow first contact to be made with an individual believed to be armed with an unarmed civilian. And so those will go to crisis negotiation under the advisement of Mental Health Co-op.
Yeah, and I will say on those calls, we, at this time, all the Partners in Care supervisors have gone through negotiator training. I've gone through negotiator training. Our counselors do not make contact with those individuals. Either a supervisor or myself will go to one of those kind of standoff type calls. We provide a mental health consulting of the mental health angle of the situation going on, gather information from family to see if there's a mental health crisis component going on, offer support to the individual either through the negotiators or after the call to get them a crisis assessment there on scene and get them connected to help at that point, either connected with our jail team or to a hospital.
Could you make this the last one?
Yes.
Okay.
Yes, absolutely. So regarding the unhoused community, the numbers that we saw, or that you reported out, regarding the results of the 3,400 calls, you had mentioned 55% resolved on site and 5% were sent off to a psych unit. How does that compare to the unhoused community, and what does that look like precinct by precinct? Do those numbers vary?
Yeah, that's the average, but it's generally looks pretty same precinct to precinct. I think it's a little higher in central precinct when the unhoused population's a bit higher. I think that 55% may be about 5% higher off the top of my head, but I can look into that data and get it to you. I know that that team has developed relationships with Salvation Army and the Office of Homeless Services to connect those individuals to housing, and that's how those 100 individuals got connected to housing there. It is a complicated problem where complex solutions are needed, and we're just one aspect of that. But I can get you more data about that for our central precinct.
Much appreciated. Thank you.
Councilmember Coopin.
Thank you, Chair, for recognizing me, even though I'm not on the committee. I just have about 15 questions, if that's okay. No, I just wanted to elevate my deep appreciation and thanks for all you do. I have interacted in a number of situations with Partners in Care, from just general outreach to a number of folks that I've experienced in active distress, needing care, and just was so impressed and honored to watch that work and watch these folks, instead of having a potential harmful interaction, seeing, getting the help, getting engagement that they need. And, I've seen it a couple times now, and really just want to say I appreciate your efforts.
Thank you.
All right, thank you. Let me get Councilmember Weiner.
Thank you, Chair. I appreciate it. I know we've talked offline, but publicly, I want to make sure everybody in West Nashville, Bellevue, understands how much you guys have actually done to make a difference out there, and we're very, very, very grateful.
Thank you.
Thank you very much.
Thank you.
All right, thank you. Let me get Councilmember Prepty. Is there anybody else that needs to ask a question? Because I need to go ahead, and we got a couple things to do real quick. All right, let me get Councilmember Prepty, and then we'll transition to other things.
Thank you, Chair. I have just one question. Captain Brooks, with the CIT training, is there a difference in the continuum of use of force whenever a mental health crisis is identified versus just a regular call out for service?
There is not. Our use of force policy governs it. As far as a continuum, it's all the same. One thing that we talk about in those trainings is the situations when you can and cannot. As I mentioned before, there's been, I think, some misconception nationwide in law enforcement where they think use of force is only justifiable in an arrest situation. And when you think use of force, I think we picture something worse than some of the things we're talking about. But people think that if there is that use of some sort of physical force, whether it be restraint or whatever, even if it escalates to something more, then that must be in response to a crime committed. One thing that we want our officers to know is that you can apply rules to medical and mental health emergency situations. If someone had to be restrained for the purpose of administering life-saving meds, for instance, if it was medical, if they were fighting medical staff, there's federal case law on that. If there's a mental health crisis situation where, let's say, and this is an extreme situation, but similar things have happened where someone's going to jump off of a bridge and an officer were to have to tackle them to prevent them from harming themselves. Like those are the types of uses of force that we're talking about. And historically, officers might be a little bit hesitant to take a life-saving action because they think, I don't have a reason to arrest this person and I can only use force if I'm taking somebody to jail. And so that education is key for them to know that they can actually take those life-saving actions. One real-life scenario that's happened over the course of Partners in Care is someone that was suicidal and was attempting to run into traffic, and officers had to restrain them and use force to restrain them. And, there's technically, yes, I guess an officer could articulate a disorderly conduct in that if they weren't up to date on their case law about use of force in mental health situations. But since they are, and since we educate them that way, they can comfortably bring that situation safely and effectively under control and then not expose that individual to a jail cell. You can take them to get the proper level of care.
All right, thank you. Thank you again so much for being here. Really appreciate it. I know we'll be in touch to secure some of that additional information and kind of point people in the right direction who are looking for more of that demographic information and those details. So thanks again for coming. Mr. Rosenberg had to step out for just a second. I was going to go to him next, but because he's not here, I would love to invite our friends from Meharry, if you could come to the back podium and share just an update about Dry January. I can give you a minute or two to update us about Dry January. It's not something I want to talk about in December, but we're going to talk about it. Yes, ma'am, right back there. Introduce yourself to everybody and
Hi, everyone. Thank you so much for this really cool opportunity to speak with you today. My name is Samita Ravi, and I'm a second-year medical student at Meharry Medical College, and we are currently the home of Dry January USA. So Dry January actually started in England, and it's basically about helping people talk about or think about their relationship with alcohol, whether it be, you know, being sober for 30 months and seeing, or 30 days and seeing what happens, or, you know, just, you know, going back on drinking in general. So as I said, we are the site of Dry January USA, so really proud of that. And we're here today to talk to you guys about some initiatives that are going to be happening soon. We are really happy to say that we have talked about, or we had discussions with the LGBTQ caucus and the Veterans Caucus here, and we've submitted proclamations to them regarding our initiatives for Dry January. And this upcoming January, on January 7th, we're going to be kicking off with our new transformational color, yellow, to expose more people in the U.S. to Dry January USA. And the reason for yellow, I know a lot of you guys might be Coldplay fans, but in one of the song lines, you know, you look to the stars, they shine for you. Whenever you wake up in the morning, the first thing you see is a yellow sunrise. And to people who are currently thinking about their relationship with alcohol, we want them to understand, you know, every day is a new day for you to explore your relationship regardless of how that looks. And see that every day is just a new day for you to check that out. So we're really excited for this initiative, and we look forward to working with more members and to see if anyone else would like to work with us on this initiative. And I welcome any questions or comments regarding what we do.
thank you. How can the community who may be watching this find out more information about what you're doing?
I'm so happy you asked about that. So we have a Instagram page. It's a Dry January _USA. On that Instagram page, we talk about like different ways to think about your relationship with alcohol. We also have this countdown that's going on before Dry January. And we also have, we work with a few sponsors who sponsor non-alcoholic beverages, and we have some classmates of mine who they have some really cool like tutorials on making non-alcoholic beverages if you're interested in that. And also just, you know, general blog posts. For example, me and my classmates write some blog posts on what Dry January is like to people. So for example, I wrote one about how Dry January is kind of like going to the gym. You know, it's hard at first, and at first you really don't want to keep going, but then when you start doing it, you know, you start feeling really good, and, you know, you kind of see this transformation. As I said, yellow is a transformative color. So you kind of think about, you know, when the sun's rising, it's like a new day, a new you. And we also have a website that's linked in the Instagram page. And if you have any questions or would like to work with us, you can always DM the Instagram page.
Very good. Thank you so much for being here. Really appreciate you taking the time to come down and share more. And thank you for your work at
thank you
Meharry
so
to
much.
share this initiative.
Thank
So
you.
appreciate it. All right, I'm going to turn it over to Mr. Rosenberg to be able to speak to Councilmember Delisha Porterfield's announcement and your joint announcement. Wait, there we go.
Thank you, Madam Chair. Councilmember Porterfield had to step out and asked me to give a quick update on the Office of Youth Safety. The fiscal year 25 budget included $750,000 for an Office of Youth Safety, a response to the fact that young people are increasingly susceptible to violent interactions. So the mayor's office partnered with Budget and Finance Chair Delisha Porterfield, Juvenile Court Clerk Lonell Matthews, the leaders of the Southern Movement Committee, which is doing exceptional work, community partners, and Nashville Youth to develop a framework for this new office. As a result of that work, last Wednesday, Mayor O'Connell signed an executive order creating Nashville's first Office of Youth Safety. The office will be charged with taking a proactive, evidence-based, and people-informed approach to the youth safety and well-being. Specifically, The Office of Youth Safety will pilot, assess, and promote programming to prevent conflicts from escalating into gun violence and equip youth with conflict resolution skills with a focus separate from the criminal justice system. Use data and research to inform Metro government's investments in youth violence prevention and restorative programming. Gather and assess how Metro government departments can continue to build safer communities for youth in ways that reduce harmful interactions with the criminal justice system, support the development of evidence-based, people-informed anti-violence initiatives within Metro government, and develop relationships with leaders of existing restorative justice initiatives within Metro government, Metro schools, and independent agencies, and when necessary, incubate a restorative justice program. We expect the job posting for this director to be up here in early December, so this office can begin doing work that we are incredibly hopeful for. Thank you for Councilmember Porterfield, Clark Matthews, SMC, everybody who's been involved so far and will continue to be involved. Thank you.
All right, thank you very much. Anybody have any questions for Mr. Rosenberg about this? Okay, well, appreciate your time on that initiative. Couple things, and then I will see if any department heads need to share any information with the committee. We received an email, or actually I received an email that I asked the council office to forward to everybody from VOAD, which is Nashville VOAD, which is Voluntary Organizations Active in Disaster. They are having a session on December 11th from 10 to 11:30 at the Nashville Fairgrounds, and they're bringing in a national speaker related to kind of responding to disasters and kind of pulling everybody together specifically for that event. So Tina Doniger asked that I share that, and so that's gone to the council office. In addition, we do have a resolution on the agenda tonight, RS 2024-907. I'm asking the council office to share it with all of you. It is for the Office of Emergency Management, and an appreciation resolution for the life of Johnny Spite, who was a longtime volunteer with the Office of Emergency Management dating back to the late 1960s, who passed away. And so they'll be recognizing him at their annual event on Saturday. And just a couple of updates. Next meeting, we'll hear from the Police Athletic League. And then in February, we're going to hear from Chief Defender Martisha Johnson, who's going to come and speak to us about some of the kind of follow-up information related to the special called meeting series in October on domestic violence. So just to give you all a preview of that. With that, Mr. Young, do you have anything you need to share, Captain Young?
Yes, ma'am. Thank you, Council Lady Evans. I just want to give you an update. I've been, some council members have reached out about the break-ins that are occurring at the fire stations. Unfortunately, they're targeting, it seems to be targeting when they get a call and the fire station dumps out, and then they come back and several car windows or truck windows are busted out and their belongings have been gone through. Even some firefighters, EMTs, paramedics are leaving their cars unlocked, and it's not doing any good. They're still busting the windows, even when the doors are unlocked. So 883 tonight on the agenda has some funding in that resolution that will be going to us to start installing cameras at the fire stations and focusing, of course, on the parking lots. Hopefully, this is a start to stop to start deterring some of this. I don't know if it's going to completely stop it, but however, would appreciate the vote for 883. It has a lot of stuff in it, but some money in that resolution will go to start purchasing cameras and being installed at the fire station.
Thank you for that update on that and how it relates to our agenda tonight. I appreciate that. Mr. Sharp, it looks like is gone, so I'll give you the update that the Health Department, if you didn't see, did select, or the Board of Health selected our next Director of Health, and that I am understanding should be something we consider at our next meeting. There was a recording of all the presentations of candidates. It's supposed to be on YouTube. It's not there yet, so I've asked IT if they can share an update about when that will be visible so everybody can at least watch the candidate that was selected in advance of our meeting when we vote on the contract. And so just to give you a heads up about that. And also there is a last thing, and I didn't mention this previously, The pallet shelters, of course, we've talked in the past about the state kind of conditional approval. There is a working group that is working to kind of deal with all the kind of intricacies of meeting those conditions. It's ongoing, but, you know, there's a meeting happening right now, as a matter of fact, about them that I'm not on the call, but we'll be hearing a little bit more about as we get a little bit closer about the RFP and what that will entail for organizations that would like to take advantage of some of those pallet shelters. And with that, if there are not any other questions, we'll be considered adjourned. Thank you.